Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Thank you for joining me again this week. I'm Jeannie Pete, and again, we've got a great show in store. Today, I am here with Dr. Jennifer Jones, who is a PhD in speech-language pathology and has a master's in speech-language pathology. She's also board-recognized specialist in swallowing and swallowing disorders. And today we are going to talk about the different swallowing disorders, including dysphagia, and the three categories of dysphagia. So we have a big show in store for you, very important for anybody who is caring for an older adult, elderly, because as I've read some of the information that Jennifer's provided for me today, there are very big differences in the way that older Americans eat and swallow and reasons for that. And we're going to talk about preventative measures to make sure that they are as healthy as possible. Did I get that right, Dr. Jones?
Yes, you did.
Okay. So first, let's start. Let me just say welcome and thank you again for saying yes to coming on the show and educating our audiences about this important topic. And secondly, can you just give us a background of how you got into this and what it is that you do?
Sure. I actually graduated from Converse College with my undergraduate in deaf education and was hired very shortly after graduating to work in a hospital to run their deaf education program. And as a result, was observing speech pathologists and decided that I wanted to make as much money as they were and wanted to do what they were doing. So my job actually paid for me to go to school and get my master's in speech-language pathology. And I immediately, when I graduated, started seeing home health care patients, inpatient, outpatients, and all of these patients had language problems, but then a large portion of them also had eating and swallowing problems. I wasn't trained how to treat these patients in school. There were no feeding or swallowing courses at the time. So I started learning on my own, reading every book I could get my hands on and going to all the courses. And after a few years of practicing, I then decided I needed to learn even more, and that's when I went back and got my PhD. And from there, it's just every year learning more and more and more about it, and then you just kind of become the specialist in the area because you've been doing it the longest, and you see most of those patients. So as you see 8 or 10 patients a day that have that problem, you get better at it.
And, as I read your questionnaire, for my audiences, prior to each show, I send a questionnaire to all of my guests so that I can be informed and know the right questions to ask to get the important information on each topic to you each week. Jennifer, you did a great job with your questionnaire. But as I'm reading your qualifications, where you are board-recognized specialist in swallowing and swallowing disorders, I'm surprised to see, being in this industry for so long, that there's only 202 board-recognized specialists worldwide?
Well, most of them are in the United States, and this is a new recognition that started, I don't know the exact date, but I'm thinking it started around 2006. I should know that date better. But and it's a pretty rigorous process of going through it. You have to show years of experience and that you treat and work with these patients on a full-time basis. And you go through an interviewing process and a testing process in order to be considered.
And, you even in the title, speech-language pathology, you understand that you have to help people who are having difficulties with their speech. But to me, it makes sense because I've been in this industry. You don't necessarily associate that with swallowing. But for me, being in home health and hospice for so long, I know all of those muscles that are needed, and it would go hand in hand to me. So it's surprising to me that you had to do so much self-study to truly learn your trade.
Yes, and actually across the globe, different disciplines are treating patients with dysphagia. We would like it to be a predominantly speech-language pathology area, but there are also occupational therapists who sometimes treat because they have more experience in it, which makes sense because they're working with these patients on using utensils and getting the food to their mouth. So then sometimes they end up being the ones who also work on what happens once it hits the mouth. But we prefer for it to be a speech pathology field, and a lot of the billing codes are speech pathology specific, and you can't bill them under an OT. But it depends on the region of the United States and what part of the world you're in.
And they're trained differently. So really,
Absolutely.
You'd get more specific to what your actual natural issue is to use a speech pathologist. Is that right, speech-language pathologist?
Absolutely, because when you're trained in speech-language pathology, they focus on all the muscles of the head and the neck regions to where you will know more of what is going on with the swallow and with the oral phase when they're actually eating and chewing up the food, whereas the occupational therapist is not going to be specifically trained in all of that.
Okay, so I've seen a lot of this throughout my years because I have worked in home health and hospice, and a lot of folks that I've worked with do have a form of dementia which does affect the muscles and swallowing eventually. But let's back up for just a minute and talk about what might cause a swallowing disorder.
Well, most people know of things like a stroke. Most patients that have a stroke are going to have some form of dysphagia. It could be oral, where they have difficulty chewing the food or moving the food around in the mouth with the tongue. Another problem that has that oral problem is like a Parkinson's disease, where their tongue pumps on a regular basis and they have difficulty getting the food out of their mouth. Head injuries can also have trouble swallowing. Myasthenia gravis, I think, is a diagnosis that a lot of people are aware of, where you just have general overall muscle fatigue, but it also affects the swallowing mechanism. And some patients actually develop problems with swallowing from medications that they're on. It's considered an iatrogenic dysphagia, and the medications that they're taking can actually slow down the response from the brainstem, and that then would cause them to have some slow response times in their swallows. So they may not realize it, but they'll have excessive coughing and some aspirations while they are eating their food. And an aspiration is when the food or liquid goes through the airway and into the lungs.
Yeah, boy, you've given me about 15 questions just in that last couple of sentences. But, as you were talking about stroke, I remember I got a phone call. I guess I was in my early 30s. I called home to just say hello to my father, and he sounded like he just got bit in the tongue by a bumblebee. And he's talking, and I said, "Are you okay?" And he said, "Yeah, I'm fine. I said, "No, you're not." And he said, "No, darling, I'm fine. I got to go to the bathroom." And I hung up and I said, "Okay, he sounds like he just got bit by a bumblebee." And so I called my brother-in-law and I said, "I think my dad just had a stroke." Is that something that you typically hear from family members, if they have that kind of a mild stroke, that their speech sounds like their tongue is swollen?
Yeah, that's actually called a transischemic attack, or a TIA, which is a mild stroke. And people can have them and not even know they've had them. And you might just see like a momentary slur in their speech, or a momentary weakness on one side of their body that goes away, or like a tingling sometimes. And some people don't even get a symptom. They might be so small. And there's actually a type of dementia called multi-infarct dementia, where they have a lot of little strokes that eventually all those little strokes on the brain end up causing larger effects.
So when does somebody come and see you?
Generally, it's unfortunately after they've either started losing a lot of weight, or they just complained so much to their physician that the physician's like, "Okay, this must be an issue, so we'll refer you out to speech pathology." But some of the type of symptoms that we see in our elderly population that don't have an etiology, they may have trouble swallowing their pills.
Okay.
So that might be something that we get. And the reason they have trouble swallowing their pills is because when we eat, we don't think about every single bite we swallow. We think about chewing it sometimes, but then once we start to swallow it, it's a neurogenic thing. It's taken over by the brain. We don't think about it. But when we go to swallow a pill, we actually have to think about swallowing that pill. And so that makes the process a little bit harder for patients. So another thing, some of the elderly population may have a drier mouth, and dry mouth makes it harder to eat or swallow, so we may get a referral from those patients.
So dysphagia, is that just a broad term that says you have trouble swallowing?
Yes, it is. It's disorder of the swallow.
Okay. And I'm reading on your survey, on your questionnaire, how many Americans are affected with dysphagia? Holy cow.
Yeah, 15 million.
Well, that's a lot.
Yeah, so the CDC estimated more than 1 million people in the U.S. annually are diagnosed with dysphagia. So as our population continues to get older, we're going to see those numbers rise.
And you also say here that of that million, or 15 million, I guess, 60,000 Americans die annually from complications associated with dysphagia?
Correct. And generally those complications would be things like a pneumonia.
Aspirating.
And if you think of, yes, aspirating, which then causes a pneumonia. And if you think about our patients, some of them are bedbound, and those are going to be your highest risk patients because they're not up and moving around, which helps to move the cilia in the lungs to kick out bacteria to help them get well. So when a patient has a stroke or something else that puts them in the bed and they're not actively getting up and moving around, and then they also have a dysphagia related with that, their risks of getting pneumonia are going to be increased, which is then going to increase their morbidity rate.
So let's talk about what you can do and how you help and what kind of treatment is out there for people who do have dysphagia.
Typically, what would happen is it would be diagnosed or discussed with their physician first, and the physician would order what's called a modified barium swallow study, and that is done in the radiology suite at a hospital or a surgical center. And what they do is they watch the patient swallow liquids and different foods with a barium mixture, which is a contrast, so they can see how it's going through the body, what's happening with the anatomy and the physiology during the swallow. It describes everything with those different foods, and it gives you a picture of what the problem would be. It would tell you whether or not the patient is aspirating. If they're aspirating, when are they aspirating? Is it before, during, or after the swallow? And then why are they aspirating? What is happening to make them aspirate? Is it a structural problem or is it a physiological problem, like their sensory system is low, so they don't know to protect the airway and that the food or liquid is coming down? So once they have that study, then they would, depending on what the outcomes are of that study would then go to a speech pathologist who would treat the patient based on the results of the study and other information that they gather from the patient's history and doing a clinical assessment right there with the patient as well.
Okay, so then once you're called in, what is it that you do to help them?
Well, it depends on the diagnosis of the patient. If they have an etiology where they're going to get better, so say they've just had a stroke and you expect them to, the prognosis is good, that they are going to recover and you expect them to get better. Then you would start doing different therapeutic techniques with them, some exercises, and maybe even altering their type of their diet. So we may put them on an easier diet to chew if they're having difficulty chewing. I know one thing a lot of people know about is that their liquids can get thickened. Thin liquid moves very quickly. And so if you have a slower system sensing that the liquid is coming down and you can't prepare in time, then what the therapist would suggest is to thicken the liquid up a little bit to slow the liquid down to give your system time to protect your airway for when it comes in.
And I know
some of the things, I'm sorry.
No, go ahead. I'm just remembering when we went through the stroke with my dad, he'd come home and he'd have to do almost what seemed like singing exercises. He'd sit in the living room, to try to, strengthen the muscles in his throat. Do you do that
Absolutely.
as well?
So if he was doing some singing stuff, they were probably trying to strengthen his vocal cords. So if there's any damage to your vagus nerve or your 10th cranial nerve, your vocal cords are not going to close as well, and your vocal cords are one of your protective mechanisms. Now, if the liquid or food gets all the way down to your vocal cords, you've also got some issues of protecting food from just going into the airway, not even all the way down to the cords. But what you'll do is you'll do some exercises like pushing and pulling. Anything that requires a buildup of pressure helps to close off those vocal cords and the airway. The singing types of things you talked about, doing some things like those kinds of types of exercises help as well. So it just depends on what the diagnosis is. Not all patients are treated the same because their etiology makes a difference, and then also the reason for an aspiration would make a difference. And then some patients are seen not because they're aspirating, but because their chewing or their movement of the bolus is so slow and sluggish, they're not going to eat enough to maintain their weight and their nutrition. So they may need help just with the oral phase and helping them to strengthen the tongue muscles and the bite and the chew to where they can eat faster and more efficiently to get in enough calories.
And, I can just imagine how scary this is for a caregiver. You're almost sitting there waiting for them to aspirate and have pneumonia and end up in the hospital. So what can you do for someone not stroke-related who you know that this is going to be a long haul? Why don't you give me some of the information on how you work with them?
So this is a patient that's not necessarily going to get better,
right.
Someone who has a long-term illness. Generally what the therapist is doing then is they are putting them on as safe a diet as possible, and then they're monitoring to see if there's any negative changes. And basically what we're doing is we're slowly downgrading their diet. So they may initially just be removed from things that are hard to eat, like lettuce and breads. And then they may be reduced down to having their meats chopped as opposed to having a whole piece of meat there in front of them. And then slowly they would move down to a pureed diet there's no chewing involved at all. And then that's when they reach the point where they can no longer eat. The family needs to make the decision with the patient as to whether or not they want to choose alternate nutrition.
Yeah, and I do want to talk about that too. This is very difficult, when you do get a diagnosis of dysphagia, because a lot of times it isn't going to get better unless it is like in a stroke case. And then you end up down on the journey toward G-tube or not, correct?
Well, I'm going to disagree with you on your comment that a lot of times it doesn't get better, because I actually think that the way that therapy has been going and the therapeutic approaches, actually most of these patients do get better. The handful of times when they don't get better is just those patients who have, more of a life-threatening etiology, which, even our patients now who are having tumors and having their whole tongue removed and several other structures within the throat are still able to get back to eating.
Wow, that's wonderful. And a case where I'm very glad to be wrong.
Yeah, I actually think there's a lot more hope for people now for eating than there was 20 years ago.
So then I want to talk more about how we do that. Can you help me visualize how you help them strengthen their muscles? I want to give that hope to our audiences. So I guess help me understand how you're helping them as well. Okay,
well, say for an example, the patient is having difficulty from the oral perspective of moving the food around in their mouth and chewing it. Mm-hmm. With that particular patient, we would work on strengthening the muscles for biting and for chewing, and we can do that with therapeutic tools that we have them bite and chew on, and we do that with range of motion, having them open and close, and we also do that with using resistance. So having them bite down on something where we give a slight pull against them, nothing hard. We don't want to break any teeth or plates or anything, just a slight resistance. Having them use different levels of what we call chew tubes some of them are really easy to chew and they get harder and harder to chew. And having them do this over and over, because these are all muscles. Mm-hmm. So just like the physical therapist is working on getting them to walk again, we have to work the muscles as well to get them to be able to eat. So while we're working on those biting and chewing muscles, we would also be working on the tongue range of motion. The tongue has to be able to move from side to side. It has to be able to retract in the mouth or pull back in the mouth, and then dissociate, meaning the back of the tongue has to stabilize to allow the front of the tongue to move and put the food on the teeth and then hold it there while they chew. And if they've had a stroke on one side of their body, then the tongue is not going to be able to then pick the food up and move to both sides, because the tongue is also going to be flaccid on one side of the tongue or weak. It's not going to move to both sides, so you have to increase that range of motion of the tongue. In the meantime, what you can do is feed the patient on the stronger side and have them do a head tilt so that they can still be eating something by mouth, because what we say in our field is the best treatment for swallowing is swallowing. You don't want to take them off of food and liquids altogether unless they are the severest risk, because the more they use the muscles, the better the muscles are going to get, the faster they're going to respond to food.
And you know, that makes perfect sense, because just like for folks going through weight loss regimes and they're going to the gym now for the first time, they're developing their muscles, they're getting stronger and they're getting faster because their muscles are working better. And so why would that not work the same way in the mouth, with the tongue, and in the throat? So
absolutely.
So great. And there is lots of hope for folks that are struggling with a swallowing disorder.
Sure. We have a huge field of researchers that are using different techniques to strengthen the tongue, different devices that are coming out that we can use with these patients in the clinic, where you have them put a bulb or a device on their tongue that they can push against the palate to build the strength of the tongue, because research shows that there is a direct correlation in the amount of tongue strength you have to have in order to swallow heavier consistencies and heavier thickened liquids types of foods. You have to have tongue strength, because your tongue is not just in the mouth. Your tongue goes all the way down into your pharynx, and it's part of the propulsion process of moving the food through the pharynx and getting it down into your esophagus.
And you know that I love that word, because that's exactly what I'm visualizing, propulsion. We don't think about the propulsion that goes on when we swallow perfectly healthy, and we never have to think about it. But when you lose that, I can't even imagine the work that it would take to get that back.
Correct, yes. And, you know, you already, as you get older, have a decline in your natural pressures of the muscles and their ability to squeeze as hard as they normally would. And so then you compound that with having a stroke or something that then again weakens those muscles. It even makes it harder.
Okay.
But there are some really good exercises that we can do to even strengthen down into the pharynx. One of the things that most people will talk about that there's a lot of research on right now is something called electrical stimulation, which really started in the physical therapy realm, where they would put electrodes on and they would send a current through large muscles to try to get some movement in the legs or other areas. And so now there's actually a lot of research on electrical stimulation and placing electrodes on the neck in various locations to help with movement in the neck to regenerate those muscles.
There's so much more to talk about, and you know, I'm always amazed at how quickly the half hour goes. So we're going to have to take a quick break, but before we do, can you please give information on how someone could get in touch with you if they had questions about a loved one that might be suffering from dysphagia?
Absolutely. My number for my office is 706-364-6172, and my email address is Jennifer, JENNIFER, at T as in Tom, IOF as in Frank, GA, like Georgia.com. And they're welcome to send me emails.
Great. And again, we're talking to Dr. Jennifer Jones, and she's with Therapeutic Interventions of Georgia, based in Augusta. And again, her phone number is 706-364-6172. But we do have to take a quick break, and I want to talk more about this electrical stimulation and how we can help patients suffering from dysphagia. Then I want to get into the 3 different categories. There's so much more to talk about. So stay with us. We'll be right back. Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Welcome back, and I am still here with Dr. Jennifer Jones of Therapeutic Interventions of Georgia, based in Augusta. And we are talking about swallowing disorders and how she can help with a diagnosis of dysphagia. But first, Jennifer, why don't we talk about what are the signs and symptoms that a person would know that they're having trouble swallowing, that they might have a dysphagia? It might be more serious than just trying to clear their throat.
Well, the number one thing that doctors look at is weight loss or upper respiratory infections or recurrent pneumonias. So those are the things that are measurable that someone can see. Other things that we would see is if they have pain when they're swallowing, or they say when they swallow it feels like something's getting stuck in their throat, or if a caregiver notices that one of their family members is eating a significantly less amount of food, or is taking a much longer time to eat the food that they do have. Another thing patients will do without really realizing is they'll switch consistencies of food. They may start drinking more or drinking less because either the food is having difficulty going down, so they might start drinking more to offset how much they're eating, or they may start drinking less because they're having difficulty managing liquids. Coughing is definitely one of the common ones that we see, and it can appear as just merely clearing their throat while they're eating, which was something my own mom was doing about a year ago. She just started doing it, and I was picking up on it, and I asked her why she was doing this and asked her if she was on any new medicines, and absolutely she was on an anxiety medicine, and as soon as I told her to get off the medicine, her coughing stopped. And so, again, watching which medications you're taking to see whether or not they're going to cause swallowing problems. And you can also have a temperature elevated about 30 minutes to an hour and a half after you eat, which can also be an indicator that you're having some aspirations. And many people think if they don't cough, that they're not aspirating. But if they have had some TIAs or they've had a stroke, their coughing mechanism may be weak, and they may not be sensing that there's something going into their airway. So they may be aspirating silently, which is hard for those of us to imagine that have a normal system, and we have the slightest little thing go near our airway and we cough for 10 minutes. But for these patients who don't have a proper sensory system, they may not have any clue that it's going into their airway.
Do you find that doctors are proactive at referring patients to you, or do they really have to advocate for themselves and make sure the doctor understands how serious this is?
Well, I think it's a combination of things. I think it's a combination of, one, the doctor's experience level, how long they've been practicing. I think it's, with our adult population, it is the patient, how often that patient is going to push. They have to make sure that they are persistent in telling the doctor and be specific in what their needs and their problems are, not just saying, I think I'm having trouble swallowing. They need to be as specific as possible. And if it's your child who's having a feeding or swallowing problem, you really have to be specific, because it tends to take months before a doctor refers a child for therapy, because they tend to say they'll grow out of it.
And what might be some reasons why a child would have some difficulties?
Well, there's, again, a lot of different types of diagnoses for children. Some of them could be that maybe the child had a choking incident at one point, and so now they have a psychological reason for not wanting to eat. They think everything's going to get stuck, so they stop eating because of that. And that's an easy fix generally. You can take them in and do the swallow study and show them that the food's going down, and then they'll start eating again, most likely. But children can be born nowadays. Children are born earlier and earlier, and prematurity is one of the biggest causes of referrals for feeding and swallowing, because if they're born prior to the time when they learn how to suck and swallow in utero, then they don't know how to do that when they're born. So they have to be taught. So they have difficulty on the bottle.
So, they're typically pretty good about referring to you, but we still do need to advocate, and don't let it go, because it is a muscle we're talking about. So the sooner you can catch it, the better off you're going to be, because you won't have further weakening of that muscle, correct?
Absolutely. And, as the doctors start referring patients and seeing the results for those patients and the increase of quality of life, which I think is a big thing to look at with these patients, then they refer more patients. And, we are a fellowship environment, but unfortunately most of our fellowship is around food or drink. And so when you have a patient who has a swallowing problem, they tend to not fellowship anymore. And that in turn ends up decreasing their quality of life and increasing their depression. So then you have a whole host of other things that are falling into play. And so those doctors are hopefully starting to look at quality of life a little bit more and may see these swallowing problems as a bigger issue to refer for.
And that's so much about how we feel about ourselves. You're right. The fellowship of it, just drinking with someone, eating with someone, the social aspect of that keeps you alive and encouraged about the rest of your life. So if you take that away, I also had a relative who had throat cancer, and they ended up with having to speak out of the button in their throat. And he said, I regret it. I wish I never had it put in because I feel like a robot just walking around. Yes, I'm alive, but we took the fellowship away.
Yeah.
Sad. Okay, so there's a lot of things we can do. We don't want to get you to those points where you don't have that fellowship. If you are a caregiver taking care of a loved one that you see making adjustments to their diet, like Dr. Jones had mentioned, for instance, switching the consistency of food that they're eating, drinking more or less, losing some weight, advocate for a swallow study because there's so much that a speech pathologist can help with and get them back to fellowship. Now, let's talk about the therapists, and are they all trained in swallowing? How do they know who the right person to go is once they do get the referral? What are the questions they need to ask to make sure they're seeking the right help?
Well, I think you need to research the therapist just like you would research your physicians. If you find that you're diagnosed with something, you're not going to just go to the physician who's closest to where you live. You're going to go to the physician who has seen numerous patients with this problem and has good outcomes with those patients. So you want to do the same thing with therapy. If a therapist is in school, when they're in school, they might have one course on swallowing disorders. They might. Some programs do not have it, although our guidelines now are requiring schools to start teaching swallowing disorders in schools. You may have had somebody who graduated 5 years ago and didn't get anything and then went and worked in the schools for 5 years and now has decided they want to work in a hospital and they've never had any training in swallowing disorders.
Wow.
So you have to be careful. Do your research. Make sure they've not only had training in it, but they've been practicing in the field for, several years. Because I wish I could go back 20 years ago and see some of the patients I saw when I first got into this field because I know I could help them now. Back then, I was the only therapist serving 13 counties. And so they were stuck with me. So I had to learn as much as I could to help them. And as much as I tried, I know I was inadequate because I was young and out of school and didn't have the training I needed.
And boy, with our aging population, seems like this could be a field we really should encourage people to go into because there's such a need and it's going to be a growing need as our population ages. And it's one that provides hope. We can help them. We can make them better.
Absolutely. We currently have about a 30% need for speech pathologists. So even if we put out 30% more therapists every year than we currently do, we would only be meeting the need.
Wow.
So if you're a speech pathologist and you're out there, you pretty much can work where you want to work and you can almost name your price. It doesn't matter if it's pediatrics or adults. It's hard to find good therapists and keep them because they bounce around and accept other jobs so quickly because they can.
Right. Now I'm reading your some of the statistics you provided me with, and I want to educate the public on this one here. One study estimates that 10% of deaths within 30 days of admission among hospitalized patients with stroke are attributable to pneumonia, and that one death could be averted for every 11 patients if they could have just gotten to you sooner?
That's correct.
So, folks, if you have a loved one that has suffered a stroke, maybe in the hospital right now, make sure you are being an advocate to get a speech pathologist in there. If they have that speech trouble or that swallowing trouble, they're not able to eat, don't just go by the care plan that the hospital is giving you. This is why I'm blessed to do what I do. I didn't know this. I didn't know that I should be advocating for a speech pathologist in case of stroke victims. So, Dr. Jones, I can assume this is not being as proactively referred as it should be. So for the folks listening that are taking care of stroke victims or have somebody in the hospital right now, they do not need the doctor to write an order for that. They can go ahead and do their own due diligence and contact you, and then you can give them the proper words to talk to the doctor to get the order.
Sure. We can't see them without a doctor's order. Speech pathology is a doctor-referred field. You can't just come to a therapist. But you can call the doctor and say, we've received a phone call from such and such patient and they're concerned about this, so we've directed them back to you to get a referral for us so that we can see if we can help them with the problem.
And see, a lot of people aren't, you and I work in healthcare, but they're just not aware that sometimes just getting that extra help and having you contact them can help them. And if we can prevent 1 out of every 11 deaths, then we did a great job here today.
That's true. And, it's over the next 20 years, the numbers of patients or people over 65 is going to double. And that means that we are going to be seeing this twice as many times as we see it currently. So we do need to make sure that we're watching out for our parents, our grandparents, and making sure that we're helping them to spot a problem, because sometimes they feel like they're a burden and they don't want to mention one more thing that's wrong. So we need to be the people who notice those signs and symptoms that they're having more coughing or changing in their eating habits, and specify, are you having problems with this? Maybe we need to go see your doctor about this, because maybe the patient themselves won't bring it to light.
Right. And I just want to stress again how important it is, because this is something that's just maybe a side thing to a more major, well, it is a side symptom to a more major situation that's going on. But this, the help with dysphagia, again, brings back the fellowship, which has a trickle effect on people's health, because when they can participate in fellowship, when they can have those social meals or drinks or sit around because we're helping them strengthen the muscles and swallow and participate, that's going to trickle down to the rest of their life, and probably even make the rest of their life longer, because they have something to fight for, to live for. They're still enjoying their life.
You're absolutely right. And, another thing they can be looking at is medications and watching the medications. I know we've mentioned that a couple of times, but just because the medication doesn't cause a swallow problems, the medications may cause drying of the mouth, especially in the South with the antihistamines and things that we take. If the mouth is dry, it makes it very difficult to swallow. So like anyone in your listening audience right now could try to swallow 3 times in a row, and you can't get to the third one. Because
I'm doing it right now.
Yeah.
It is. It's hard.
Your mouth gets so dry, there's nothing in there to swallow. And that's when it causes a problem with oral care and making sure that we're keeping our mouths good and clean, cleaning our dentures, because most of the sickness that comes from aspirating is from the bacteria that's in the mouth that's getting carried into the lungs, as opposed to the actual food that's going into the lungs. So another big thing that these patients can do to protect themselves is to make sure they're cleaning their mouths, good oral care multiple times a day before and after they eat if they're high risk, because then they're going to get rid of all that bacteria before they eat. And
what a small thing to do for such a large reward.
Correct.
That's great. So let's talk about the different types of dysphagia, the categories.
Okay. Well, generally, we lump them into categories of a neurogenic, a mechanical, and a developmental. And basically what neurogenic means is it's any type of disorder that's going to occur in the brain. So your strokes, cerebral palsy, dementia, traumatic brain injuries, Parkinson's, and multiple sclerosis, any kind of tumor that's growing in the brain that would put pressure on different portions of the brain or the brain stem. We mentioned myasthenia gravis earlier. these are all considered neurogenic. They're things that are occurring in the brain that would cause changes to how you swallow, because swallowing is a relationship with the cranial nerves that are in the medulla and pons of the brainstem. So if you have a deficit in the brain, it's going to affect the outcome of what those cranial nerves can then tell the muscles to do.
Okay, so what are the top 2 or 3 things you do for someone suffering from neurogenic dysphagia? I know we talked about some of that, but I'm going to try to simplify the 3 categories and what the top things are for each.
Well, the first thing you'd probably do is give them some form of an indirect change, like just altering their meal, and maybe even altering their position, or giving them a maneuver like tucking their chin or turning their head, which will help protect their airway. So that's like an indirect type of thing we would do based on what we see in the swallow study.
Okay.
And then directly we would see them in therapy to either do electrical stimulation, oral exercises, swallowing exercises where we give them stimulation and then ask them to swallow. We can also do hook them up to EMGs and give them visual feedback to teach them how to swallow harder.
What's an
and it
EMG?
Will give them visual. It's electrodes that you put on the muscles, and whenever they squeeze the muscles, then they get a visual representation on a computer or on a screen that will show them how hard they're squeezing. Because sometimes it's hard to say, squeeze harder, and they don't understand that.
Right. Okay. Great.
So that's the main things we would do with neurogenic. Obviously, they're all different. Mechanical there are patients who typically either the muscle is removed because of cancer. So any of our ectomies, like a glossectomy where the tongue is removed, a laryngectomy where the larynx is removed, which is you were talking about with one of your family members,
mm-hmm.
A mandibulectomy where the actual jaw is removed. So there's different types of ectomies in there. That's also the types of things where you have some people have heard of a Zenker's diverticulum, or a pull-away pouch inside the esophagus that is causing food to pull into a location. So a tracheoesophageal fistula is a hole between the esophagus and the trachea where food can go down the right way into the esophagus, but then it might jump through this little hole and go over into the airway and cause the pneumonias. So there's no swallowing problem per se, but there's a problem lower down in the esophagus.
So what do you do for those folks? This sounds scary.
Yeah, those are surgical repairs.
Okay.
Most of our mechanical patients have either had surgery or will need surgery.
Okay.
And so we're coming in before, during, after, and we're also doing a lot of counseling to help them understand what's going to be coming next. And COPD, or obstructive pulmonary disease, those are patients who would also fall underneath mechanical, because the number one priority in life is to breathe.
Right.
And when we swallow, we have what's called an apneic phase, or a period of when we actually hold our breath. And so those patients have difficulty generally because they can't hold their breath for a long period of time during that swallow. So we have to alternate how they're eating to where it requires them to hold their breath for the smallest amount of time.
Wow. And so, again, I mean, this just sounds so scary, but you can still help these folks even after the surgery by reteaching how to swallow to avoid what their issues are? Absolutely. Retrain the swallow, just like retraining them to walk or retraining them to use their hands. You're doing the exact same thing as retraining the swallow. Okay.
And some surgeries they can have, like a cervical fusion where something's put in on their spine. They go in when they do those surgeries and they push all of the muscles and nerves out of the way to get to the spine, especially if they go in anteriorly through the front of the neck. So what they're doing is then they will cause those patients to have some swallowing problems for a short period of time. And then as those nerves and muscles get back to normal function, then the swallowing problem will then go away for some of those patients.
I see. And then the last category is developmental.
Correct. And that's mostly what we see in children. But we can also see that in our patients who have any kind of cranial nerve palsies. And these are patients who generally are not going to get better. These are patients who are going to have long-term problems. They've had traumas. They've had lack of oxygen to the brain. They've got basically a central nervous system injury of some sort that's not going to get better. So what we're doing with these patients is we're trying to give them the best way possible for them to eat so that they will be able to continue to eat something by mouth. They may need an alternate source of nutrition, but then they can also have that quality of life by having some food by mouth and keeping those muscles moving on a regular basis.
And see, I think so many times, just in my history in hospice, we see the G tubes, and we hear from patients so much, I just want to eat something. You know, it's psychological, it's emotional, and even though there might be a different way to get nutrition to keep you sustained, to keep life sustainable, to be able to eat, I don't think people realize just how important that is. So you can still do that even with these developmental types of disorders.
Absolutely. And a good therapist knows that their ultimate goal is to get the patient eating something. And when you go in and you do the swallow study under radiology, that swallow study is not complete until that therapist has found something, some way that that patient can eat or drink. And they may be doing a maneuver like a chin tuck or a head turn or a swallow, cough, swallow, or they may need to have their liquids slightly thickened or their foods pureed. But whatever it is, their goal is to find something that patient can continue to eat, even if it's not to maintain all of their nutrition, to where they can work on those muscles. Because if those patients aren't working on the muscles and they just get a G-tube and they don't continue with therapy or working on the muscles, they're not going to get better.
No, they're not. And then they're going to lose their will to get better.
Absolutely.
Okay, so one thing I've learned today is that you are a gem in the industry of speech language pathologists and therapists, and that there's not enough of you to go around, and that I'm honored that you came on my show to talk to our audience about this important. You know, dysphagia affects you, like we've talked about, physically, but emotionally and psychologically as well. So what I want to do before we have to go is give your contact information again, and I'm going to make you even busier because we know they need a doctor's order to get the help. But the doctor's order might get them somebody who does not have nearly the education that you have, and you can help them make sure they get the right person to help them with their loved one. So can you give your contact information out again, Dr. Jones?
Well, sure. Before I do that, though, your program is broadcast in Atlanta?
Atlanta, Phoenix, Arizona, the Gulf Coast, Mississippi, New Orleans, yes.
Okay. So what I would encourage your listeners to do, because, I mean, I'm in Augusta, Georgia, and there's only one of me, and there are a bunch of us out there, so is they can go on the website swallowingdisorders.org, and that's the website for all the therapists that are currently board-recognized specialists in swallowing and swallowing disorders. And they can then put in their city and their state, and it will show them what therapists are in their area who are certified and trained in the field of swallowing who can help them.
Wonderful.
And one good thing is we do have several good swallowing places in Atlanta. Emory has a great head neck cancer facility to work with these patients. And, you know, because I have patients who drive here 4 hours away one way to get therapy. And as much as I want to help them, you know, I am only one person.
Right.
And so I do try to help those people find someone in their area who can help them, because life is too busy and gas is too expensive to be driving 4 hours one way to see a therapist.
Absolutely. So again, I hate to cut you off. We're out of time. But you've been listening to Dr. Jennifer Jones from Therapeutic Interventions of Georgia in Augusta. But no matter where you are, please go to this website, swallowingdisorders.org, to get in touch with the right person for you and your loved one. I'm Jeannie Pete. Thanks for listening. Have a blessed day and week ahead. And listen here, same time next week and every week. Homestead Hope Foundation is your resource for a healthy life. God bless.